Welcome to this video on patient assessment and reassessment in acute care. We will review types of assessments, timeframes, and the rationale behind them, anchored to CMS and the Joint Commission standards, and integrated into the daily workflow of the interdisciplinary team. In this video, we will explore key learning objectives. We will differentiate between screening, assessment, reassessment, and triage, identify required types of assessments, state necessary timeframes, and discuss how to embed these processes into your daily clinical workflow to maintain survey readiness. Assessment is the foundation of every care decision. It helps us understand the patient's needs, select the appropriate care setting, form initial diagnoses, and judge responses to treatment. Failure in this process can lead to significant clinical risks, such as misdeterioration. To ensure we speak the same language, let's define our terms. Screening is a rapid check for needs. Assessment is the systematic collection of patient data to plan care. Reassessment involves continuous data gathering, while triage is the prioritization of patients based on acuity. Understanding the U.S. standards landscape is vital. CMS Conditions of Participation set the federal floor for compliance. Accreditation bodies like the Joint Commission provide further guidance. Remember, if your hospital's internal policy is stricter than these standards, that policy is the auditable requirement. Assessment is a cycle, not a one-time event. From initial screening and assessment to integration, planning, care delivery, and ongoing reassessment, the loop never closes while the patient is under your care. Significant changes require the team to return to the reassessment phase. Who may assess? Only qualified individuals, as permitted by law or certification. Hospitals must define in writing the assessment responsibilities for each discipline, including physicians, registered nurses, and allied health professionals, ensuring care is always within their defined scope of practice. Timely assessment is an evidence-based tool for prevention. It helps reduce in-hospital cardiac arrests and mortality. Far from being just paperwork, it is the primary mechanism to detect and prevent serious harms, including pressure injuries, VTE, and delays in sepsis treatment. Step 1 is screening at first contact. We must determine if the patient's needs match our resources and identify the most urgent conditions. A positive screen is not a conclusion, but a vital trigger for further comprehensive, discipline-specific assessment. Regarding the 30-day validity window for prior assessments, if an assessment is 30 days old or newer, it may be reviewed and validated. However, if it exceeds 30 days, the history and physical examination must be repeated before proceed with new care. Initial medical assessments have specific content and timing requirements. A history and physical must be completed within 24 hours of admission and always before surgery. Other settings, such as critical care or L&D, may have stricter, unit-specific timeframes that must be followed. The initial nursing assessment should occur within the first hours of admission. This includes embedded screens for pain, falls, skin integrity, and nutrition. Once completed, the physician should review these findings within 24 hours to ensure that nursing assessments contribute to the unified plan of care. The integrated assessment dataset includes 3 major domains: the clinical core, which covers physical health, risk and function, including falls and nutrition, and person and context, which addresses social, spiritual, and educational needs. These components ensure a holistic approach to patient care. In true emergencies, initial assessments may be limited to the patient's immediate needs to prioritize life-saving care. Even in these situations, certain documentation such as medication allergies and a brief preoperative note remains mandatory. Once the patient is stable, the full assessment must be completed. Finally, the risk screening bundle should be applied at every admission. This includes screening for pain, nutrition, falls, pressure injuries, VTE, delirium, neurostatus, dysphagia, and social needs. Remember that these screenings must be rerun whenever a significant change in the patient's condition occurs. Let's begin the risk screening bundle with pain assessment. U.S. practice has shifted away from using pain as a mere fifth vital sign. Today, the focus is on how pain impacts sleep, breathing, and daily function. Effective assessments capture onset, location, intensity, and a realistic comfort function goal. For pain, matching the tool to the patient is key. Self-report is the gold standard. For the very young, sedated, or cognitively impaired, we use validated behavioral scales like FLACC or CPOT. Remember, a patient's tool may change as their clinical status evolves, such as moving from CPOT to an NRS after extubation. Pain assessment requires regular reassessment after interventions, typically 15 to 30 minutes for IV analgesia. When using opioids, we must monitor for sedation, as this is an early warning sign for respiratory depression. Always favor a multimodal approach to minimize opioid reliance. Next is nutrition screening. Undiagnosed malnutrition increases infection rates and hospital stays. Aspen standards dictate screening every admission within 24 hours. Validated tools like the MST, MUST, or NRS 2002 help us identify at-risk patients who then require a formal assessment and a tailored nutrition plan. Functional and mobility assessments are essential to protect patient independence. We track activities of daily living and gait. Early establishment of a baseline helps us detect declines that might otherwise go unnoticed. Remember to reassess whenever the patient's condition changes, such as after a fall or surgery. Falls risk assessment is critical. Tools like the Morse Falls Scale, Hendrick 2, or Humpty Dumpty for pediatrics help guide targeted prevention. Universal precautions like clear paths and low beds apply to everyone, while high-risk patients require intensive bundles. Always conduct a post-fall huddle after any incident. Pressure injury risk is an important outcome measure. The Braden Scale, with its 6 subscales, is the standard for assessment. Our prevention bundle, which includes regular repositioning, keeping skin clean and dry, and optimizing nutrition, is vital, and skin must be reassessed at the start of every shift. VTE risk is a leading preventable cause of hospital death. Risk stratification upon admission using the Padua or Caprini tools is mandatory. Once the risk is identified, we must align prophylaxis accordingly. Consistent application of these protocols is proven to drastically reduce symptomatic DVT and pulmonary embolism. Sepsis screening is time critical. The Hour 1 bundle includes measuring lactate, drawing cultures before antibiotics, and administering fluids or vasopressors as indicated. Delays in treatment significantly increase mortality odds. We screen actively, reevaluate after resuscitation, and treat every hour as vital. Delirium is often the most missed diagnosis on the ward. Many cases, especially hypoactive forms, are overlooked. Using tools like the 4AT or CAM at every shift improves detection. Management focuses on non-drug interventions, including reorientation, sleep hygiene, and mobility, alongside reviewing potentially deliriogenic medications. For neurological assessment, the Glasgow Coma Scale provides a consistent framework for monitoring. When suspecting a stroke, use the BE-FAST acronym: balance, eyes, face, arms, speech, and time. If a stroke alert is activated, ensure the patient remains NPO until a formal swallow screen is performed. Dysphagia screening is a critical safety step, particularly in stroke care. Nothing should be given by mouth, including medications, until the patient passes a validated bedside swallow screen. If they fail, they must remain NPO until a speech-language pathologist completes an evaluation. Our assessment must also be comprehensive, covering psychosocial and behavioral health needs. This includes screening for depression, anxiety, cognition, and substance use, alongside mandatory suicide risk screening for at-risk patients. Always use a trauma-informed approach to ensure patient safety and build effective support networks. Finally, we address health-related social needs. Screening for food, housing, and transportation insecurity is vital because these factors directly affect recovery. However, screening is only effective if we close the loop by connecting patients with the appropriate community resources and verifying that those needs were met. Lastly, ensure you address the patient's spiritual, cultural, and educational needs. Understand their values, provide qualified interpreters when needed, and use teach-back methods to confirm they understand their plan of care. These steps ensure our assessment is truly holistic and supportive. Special populations, such as neonates, older adults, and oncology patients, require tailored assessments beyond the core bundle. Each hospital's policy defines these groups and specifies the additional elements necessary for their care, ensuring their unique developmental, physiological, or treatment-related needs are met. For palliative and end-of-life care, the assessment focus shifts from cure to comfort and dignity. This includes managing symptoms like pain or breathlessness, even when the patient cannot self-report, as well as supporting the emotional and spiritual needs of both the patient and their family throughout the process. Outpatient assessments are right-sized to the visit. We move away from the full inpatient bundle to a focused history, exam, and medication reconciliation. However, setting specific screens, such as depression or falls risk, remain essential, and clear red flag protocols are mandatory for safe escalation. In peri-procedural care, the pre-procedure gate ensures no patient proceeds unassessed. We must verify a current H&P, NPO status, medication review, and site marking. Crucially, a qualified provider must perform a final pre-induction reassessment to confirm nothing has changed since the pre-anesthesia assessment. Recovery monitoring follows a ladder of intensity that steps down as the patient heals. Each phase, from PACU to the ward, requires specific criteria to proceed. We document that the patient meets these milestones. Recovery status is always measured, never assumed. Post-operative reassessment requires reading the trend, not just a single snapshot. We measure vital signs against the patient's individual preoperative baseline. A sustained deviation of around 10% from that baseline should prompt a full reassessment and potential intervention. Inpatient floors follow a daily rhythm. Physicians reassess at least daily, and nursing reassesses every shift or more frequently based on acuity. Importantly, we must trigger an immediate reassessment whenever there is a significant change in the patient's condition or upon the crossing of a warning threshold. For patients awaiting placement, custodial care does not mean an absence of assessment. We must maintain vigilance for clinical deterioration. Weekly physician assessments, alongside ongoing monitoring of skin, nutrition, and function, ensure the patient is safe while waiting for the next level of care. Early warning scores provide an objective alarm, but they support, rather than replace, clinical judgment. Whether using simple weighted scores or complex predictive models, a worried nurse or family member is always a sufficient trigger to reassess and escalate care immediately. This slide provides a reference for core inpatient assessment timeframes. Use these as a quick guide for common practice, but always cross-reference them with your hospital's specific written policies, as these are the definitive requirements during an audit or survey. This final reference table covers setting-specific and specialty assessments. Keep this handy alongside the previous table as a pocket reference to ensure you know when each specific assessment is due throughout the hospital environment. Assessment only matters if it changes care. The cycle: assess, integrate, identify, set goals, intervene, and reassess must be an active team process. By documenting our findings in a shared way, we turn data into an actionable plan that truly reflects the patient's whole person needs. In summary, remember these 10 rules. Screen everyone, follow policy, respect the 30-day H&P rule, assess pain for function, run the risk bundle, reassess for change, escalate when worried, close the loop, treat the dying with dignity, and document for the team. This updated series aligns our clinical practice with current U.S. standards, including CMS Conditions of Participation. We have refined our pain assessment approach, clarified nursing timing, and integrated new evidence on sepsis and health-related social needs, all within a concise 45-slide framework. For further learning, please consult the resources listed here, including CMS and Joint Commission regulations, clinical guidelines, and the evidence cited in this video. Always verify these sources against your hospital's specific policies to ensure full compliance.